Thank you very much. It's lovely to be here, and it's a great opportunity. I feel like I've been promoted to the smart end of the class, instead of where I used to sit at the nerdy dumb end of the class, or maybe the nerdy end that other people thought were the dumb end of the class. I think people here are incredibly powerful, and what the Minister has been clearly saying to us, people who sit on NACAC and various state federal committees, is they're looking for answers, not for problems. But together we could be incredibly powerful. I had a big argument with the then president of the AMA across the table in the minister's office when he was trying to tell me that nurse practitioners, we need to keep them under control and they shouldn't be expanding the model and moving into aged care. Now, that was several years ago, but have we really moved forward? And I would have said that the Immunisation Coalition is a great forum to actually tell the government what we can do to help, as opposed to tell them the problem, because quite frankly, we're sick of hearing the problems. Okay, why should we worry about aged care? I mean, there's only 250,000. They're becoming more like a hospice now. People are staying at home far more. Obviously, there's lots of problems with home-based packages, which I could wax lyrically on, but not happily. And therefore, why should we worry about residential care? Well, if you went to ID conferences in Europe perhaps 10 or 15 years ago, as I did with my Professor of Director ID wife, you would hear all about VRA, VRE in residential care, and it was basically a little cesspit for bugs that then recirculated back in the community from Europe, and particularly with poor use of antibiotics. And in a sense, it's the same risk with residential care. We've already heard that in many ways, we need to manage this problem because it's not death that's the problem now. Early on in VARC, when I was there, death was the real issue, and it was a daily crisis of outbreaks. But now there are more deaths associated with other respiratory, serious acute respiratory disorders. As I've said today, pertussis is rearing its head, influenza, RSV, human metapneumovirus. They're all creating outbreaks that are causing major problems, and the impacts are largely on staffing. Obviously, people here are all aware of the update in air, and the update in air is an advantage for us in residential care because we've often got people moving in there rapidly, and figuring out what their vaccination history is in a cognitively impaired group can be quite challenging. This is telling you what you already know. This is data you could have got yourself from the respiratory surveillance report. And what a surprise, if you can read the newspaper or the news feeds, you would have heard what's happened, as I've said, in South Australia, when residential care, where community falls over, when people start to come to hospital, we are so thinly spread. It's a disaster. Every morning from 6 o'clock, I start to get messages from my team of who can't come to work because they're sick, their children are sick, or someone else is sick. And if I can't put up a workforce, it becomes a huge problem in practical terms. The same thing with COVID. It's not so much the COVID-related illness, although I think what's underplayed, and I was talking to my old boss, my former boss, not old boss, Professor Michael Woodward here, who's busy circulating messages as we speak, and keeping my team up to date. The biggest problem that I'm seeing of people getting to our many beds is of people who get worsening delirium bordering on, which basically transitions to dementia. So that's, to me, the much bigger problem in COVID, and I think it's an under-recognised issue with respect to COVID and the need for vaccination. One of our colleagues talked about COVID-19 vaccinations. I sit on the board of about 15, 16 residential care facilities in the not-for-profit sector. This is an almost daily occurrence, and for those with loved ones in residential care, you can understand what the issues are. I remember when my aunt was still alive, her being locked down would generate 12 or more phone calls to almost every member of the family, as she was desperately depressed and upset about being locked away from family. And that was very much what we saw during the time of COVID. And there were literally months where we ended up not seeing her. And that was a terribly tragic time towards the end of her life, and no doubt was a significant factor in her refusal to go back to hospital or care again. our colleagues already commented on the number of deaths, and it's amazing. When I was in VAC, every single death was a nightmare for us, and we would watch the news, and every single death was ripped apart by the news media. And now we've got 50 deaths in the last 7 days, and it sort of goes by the by. Now, in truth, many of those deaths, because I've been able to look at them as part of the coalition looking at vaccination, many of those deaths are with COVID, not necessarily because of COVID. It's sometimes the nail that dislodges the horseshoe. And we've already said that we do know that COVID, like many of the respiratory illnesses, are more problematic in the elderly and the frail. The data around ICU, the tip of the iceberg sort of stuff, is well known to us, but really now with our under-recording of information, and I struggle to know what the influenza vaccination rates, and the department can't actually provide in residential care, although with time we will be able to, and it's generally pretty good. And what the rates of other RSV, etc., is simply we just don't know. Booster rates are still problematic. And they are well below what we need them to be. So in practical terms, there's huge differences between states, between different facilities, between community, between cold communities, and also some of our Indigenous and remote and regional services. This is a major concern for us, because to me, it's the canary. And if it's problematic for COVID, it'll be problematic for every other vaccination type. Now, some of it, or much of it, I think in my mind, is practical related. How do we deliver it? Okay, so obviously the new air that's been available makes our life a lot easier, and it's even better because residential care can access it, provide lists, and we've got an idea of who's been vaccinated, who hasn't. I spent a lot of my time trying to sort out people kicking the can down the road all the time, because people get admitted to residential care, particularly from acute care, and trying to figure out who's been vaccinated, who hasn't been vaccinated. As a change in general practice, it's hugely problematic. And because of our fee-for-service nature of general practice in residential care, we simply don't have time to do that background work. We don't have time to do that clinical governance work. Our attempt to put up a model for general practice where they would get a small stipend to do some of this additional work, which they have to do, but it's not funded, unfortunately didn't get up, even though we did have a coalition. So it's a practical problem in real terms of how to do it. We know about incentive payments. We know that they work. I do work with one of the pharmacists from, not Chemmart, Chemist Warehouse. Sorry, I just tried to think of the brand, who actually does vaccination, and it does, it works really well. And obviously there are primary health networks who can support and access, and certainly they're the vaccine program partners for those situations where we really can't deliver vaccinations to particularly regional and remote services. And things have got so difficult in some facilities, and I support on an honorary basis some residential care, both in regional Victoria and also just recently a bit of west coast of Tasmania, is that you simply can't get people there. It's in one place we've sadly had to abandon, the general practitioner will only see people from residential care if they're brought to their clinic. And in many ways, the patient frailty and illness is such that that's just not practical. What else is happening? Well, we've got direct calling to residential aged care homes. You'll notice they've changed facilities to homes to make it sound slightly sexier. I don't know that it's changed much, but at least I can remember they're now called homes. So we are trying to ring and trying to stimulate provision of vaccination. Nevertheless, it's a practical, pragmatic, and it's great to see pharmacy and other providers being able to support general practice who haven't got the time. I mean, I used to run 4 GP practices, and I had to be generating $3 per doctor per minute in order to keep the lights on. So just running the damn thing was almost impossible. And residential care was just financially unviable. That was our charity work. The department's providing direct assistance, and there's a link for assistance with vaccination programs. I think one of the things that acute care, and particularly in Victoria, who probably like everywhere else, do specialise in kicking the can down the road. Acute health delivery or enabling of vaccinations prior to discharge. I discharge from my various 12 wards about 7 people a week to residential care. They need to have their vaccination status sorted out prior to discharge. It's very easy for me to vaccinate whilst they're in hospital. I've got a captive audience. And I don't understand all of these subtle nuances about creating, supporting vaccination. But if you've been in hospital and you've been pretty sick, often that's a pretty good leverage into, do you want worsening dementia? Step right up. Consent. If you talk to my friend, Professor Woodward, consent's a bit of a nightmare. And we've tried to work this on AHPPC, looking at this incredibly complicated consent form. When you've got really devoted families, well supporting loved ones in residential care, oh my God, it makes our life easy. Where you can't find people for love or money, we think there's a son or an ex-partner somewhere in New South Wales, but you've got no number. It's an absolute nightmare. And 30% of people in residential care do not get regular visits. So it all sounds hunky-dory about getting a consent, but it can be absolutely nightmarily difficult. And therefore, in hospitals, I think we should be taking a much bigger role in this, because if for no other reason that the people we tend to send into residential care, 25% of those pass away every 6 months. So they're the sickest and the frailest of the groups that go to hospital, and therefore consent and its challenges should be dealt with either in hospital or in transition or upon admission to residential care. I've tried to convince the various powers that be that we need to have a consent form, a bit like advanced care directives, that maybe are not binding because that seems to be too problematic, but at least gives a strong indication that where vaccinations are appropriate and available, that they should be vaccinated. Because otherwise, when I talk to my GP colleagues, including the GPs that I actually pay, one of the big hassles is trying to get this consent, trying to sort out the consent, let alone figuring out who needs to be vaccinated and who doesn't. Well, thank you very much.
That's great. Thanks very much for another excellent talk. We'll do 1 or 2 quick questions and again, have plenty of opportunity in the Q&A. Are there any questions in the room?
Oops, nearly solved the problem.
Hi, I'm Najwa. I'm from Sanofi. I know I wasn't supposed to ask questions, but I'm itching. So just in regards to the outbreaks in residential aged care for COVID, it seems like flu vaccination rates for over 65 tend to be relatively good. So does the COVID vaccine administration piggyback on that so that they're co-administered?
Well, now it does. And probably people in the room, when I got my last COVID, because I told them I was over 65, I wasn't, but it sounded better. It's the only time I wanted to be older, because I wanted the attenuated influenza vaccine. So I got them both at the same time, and certainly it's what we recommend now, but it wasn't so long ago. See, the problem is that we're now really smart. We didn't know what the hell we were doing only a few years ago, and we were sort of guessing. So we didn't quite know whether we should do them together, apart, this many weeks apart, that many weeks apart. We argued with the smart people, not me, in the room, trying to figure out what the right answer is. Now we've just said, do it together.
Thank you.
Hi, Luda, South Australia Regional again. Under my remit, we've got 48 aged care facilities in our 6 local health networks. I can tell you now there's not a single GP that's administering COVID vaccines in the regional, and that's a shame. Pharmacy does not come on board. And I saw the numbers and they're shocking. They're appalling for South Australia at the moment in terms of how many active cases we've got going, how many outbreaks we've got going. When can we get, and this is a generic question, when can we get rid of these down multi-dose vials? When can we get rid of CVAS? When can we start ordering COVID vaccine on the NIP so that it's a standard vaccine ordering process? Because sites, it's too hard to order vaccines at the moment.
Well, I can get the single-use vaccines, but you can only get 30 at a time, whereas
Exactly.
Pfizer, I can get 600 doses at a time. Now, part of the real reason is, as you know, when you talk to pharmacists, it's about it's wasted stock. So the single-use vials, syringes, last a couple of weeks, 2 to 3 weeks, and the multi-use lasts 10 times as long. So it's just, it's a practical pragmatic. So the government is, I figure they haven't told me this and I forgot to ask them, but I figured why they're doing this is for purely pragmatic reasons. But at the same time, if you said to the government, this is my problem here, and you had a model that would actually fix it, I have little doubt, and you can use me and I'll advocate on your behalf with the government. I'm pretty sure that they would come up with a pragmatic solution. They are, at the end of the day, reasonably solution focused. So if you can come up with a sensible plan, they will actually do something about it. I mean, I now support nurse practitioners. Spent 5 years of my life going up there in my private practice and donating it to train up nurse practitioners. There are models you can actually put in place to do it, and training up vaccinators. I mean, goddamn, if an intern can do it with 4 years of training plus, you know, some wine appreciation and you know, African drumming as options, then quite frankly, anyone could.
It's not getting the vaccines into arms, it's getting the vaccines from the Commonwealth. The problem is in a regional SA, we've got 6 CVAS sites that have been approved because you have to jump through hoops just to get the CVAS sites approved. We've got 6 that have to cater for 48 aged care sites, 61 acute sites, 200 community health sites. So it's the CVAS sites that won't get approved. So that's why there's limitations or restrictions on why COVID jabs don't go in arms through the local health networks, through my aged care facilities.
So have you written to Janet Anderson, the
We're told to.
commissioner, and to write to Annika Wells and say, this is the problem and here I have a solution?
This is a Commonwealth state jurisdictional matter.
Sure. But this is the problem,
Yep.
and why I think we need a CDC type model, because,
Agree.
you know, like trying to corral the Victorian government. Oh my God. There was an outbreak team that I didn't know about for 3 months, and I should have known about. Oh, there's 5 different outbreak teams. Who the hell would design such a stupid system?
Maybe we need multiple voices petitioning this.
Yeah.